Ladies and gentlemen, welcome to the Medical 10 for 10 podcast. I'm your host, Dr. Jeff Brown. I'm joined by my co-host, Dr. Jeff Cole. Today, I'm delighted to have as our guest, Dr. Geetinder Goyal. He is the CEO of First Primary Care. Geetu, tell us about First Primary Care and yourself.
Thank you for having me on, folks. I am an internal medicine pump critical care physician. 8 years ago, started First Primary Care, which is a direct primary care clinic. And we started with the simple idea of removing insurance in between from a doctor and patient relationship. And now we redesign insurance for the big, bad, ugly stuff. So we sell health plans to companies that are DPC centric.
And when you say DPC, you mean direct primary care. So you've eliminated the Blue Cross, Blue Shield, Cigna, except in instances of what we call a catastrophic instance, correct?
Correct. Let's restore the purpose of insurance to what it was truly designed for, which is to cover risk. Primary care is not a risk.
Gotcha.
That's well said. So you said 2016, correct?
Correct.
So I think just the explosion of premiums over that period of time to today has been staggering. And I'm certain that there's plenty of data that says that wages have not kept pace. Is that would you say that that's the problem you're solving for at the core?
Absolutely. And I think the fundamental problem or the reason behind that is nobody knows what healthcare truly costs. And that's because the way we buy and sell it, everything is under insurance. If we ask anybody what is the cost of a blood work or an x-ray, nobody knows. We got to put price transparency back into this healthcare system and eliminate a lot of the waste that gets associated with healthcare when it is done behind closed doors.
And give us an idea of what you would save an employer, say of a 100-man group in a given year for a health plan.
You are doing yourself and your employees a disservice by being a fully insured health plan. You, as a fiduciary of the health plan, have to take control of your healthcare dollars, and we can help you do that through our direct primary care centric health plans.
Is there a dollar amount that you could quote for that?
Very commonly, we see 20 to 30% savings for employers, so around $2,000 to $3,000 per employee per year.
You've described how your plan works at the base level, and then at the mid level, which is more the cash pay to specialists, and then the at-risk portion, if people need to go to the hospital or there's more. Can you explain that, how that looks?
So nowadays, when we start consuming healthcare, we directly jump into the PPO network or the insurance network.
Mm-hmm.
Whereas the idea is use insurance for the bad, big, ugly stuff. Get primary care from the doctor you know without any copays and deductibles, and that's our primary care layer. Again, 65% of the care your primary care can take care of if they have time to give you. The rest, 25% of the care happens through guided cash pay care. For example, lab work. You need a PSA, my cost is $4 and I pass it to you. You need an x-ray, our cost is $50 and I pass it to you. MRI is $400, right? Hernia surgery is $5,000. ACL repair is $10,000. So there is a cash pay layer built in there, and you pay it cash. For claims that happen after the health services are already provided, for example, you end up in an emergency room, hospital, let those only hit our insurance plan and pay through the insurance.
And you were just giving some pricing there, and I think just to be clear, the patient is not seeing that expense. In fact, that's $0 to them. There's no copay. There's no you owe X when you present to the surgery center. It's
correct. That is exactly right. In all this guided care, patients' copays, deductibles are completely waived. If patient says, I don't want to listen to you, I want to go do it on my own, they have access to a PPO network, and in that case, they will pay their copays and deductibles.
Mm-hmm. But you flipped the script because so those that are listening, it's a subscription model that the employer pays monthly, but the patients have access to you as many times as they want. So you as the physician taking care of them or the nurse practitioner is incentivized to make them healthy rather than just episodic sick episodes, if I'm saying that correctly, right?
You're absolutely, again, comes back to us designing a true healthcare system and then having a better mechanism to pay for the sick care.
Another example where we see a lot of abuses and cost that just makes no sense is in the prescription drug situation. How does your prescription drug program work? Is that $0?
Exactly right. About 1,000 generic prescriptions, $0 through the plan. Again, there shouldn't be any, I feel like, barrier to accessing basic blood pressure, mental health, those kind of medications. And then we also have partners that internationally source drugs, drastically reducing the cost of drugs.
And tell us about you, a little bit of your background and your team.
I grew up in India actually. Medical school was in India, but I did my residency and fellowship here in the States. I have worked in New Zealand for 6 months, England for 1 year throughout my years. So I've understood a lot of the single payer, our US system. And I'm really passionate about redesigning a whole new healthcare ecosystem that first works for our patients and our doctors, and then everybody else. I'm an internal medicine physician, pump critical care by training, but I am really learning how to do primary care now.
Tell me about your growth. How many members did you have, say, a couple years ago, and where have you grown to at the moment?
So I had actually printed some stuff so I could, so we were obviously 0 members. January 2016, we closed the year 2023 at 6,500 members.
That's great.
We were 3,200 members when we closed the year December 2022. Revenue wise, significant growth in the last 2 years, obviously very slow. Some would argue not so slow, but I would argue very slow in the first 6 years. But it has taken us time to prove the concept, develop solid partnerships, and now we are ready to take this, on an accelerated path.
It sounds like you had to get the base level right.
Yeah.
And now you've got your sights on just redefining what insurance, what it costs, what it does, who pays for it.
Yeah.
I think there's nobody standing in your way. I think employers would be behind this. I think doctors are behind this. I think patients are behind this. Mm-hmm. It's only the large insurance carriers, and they can't stop you. So I think this is exciting.
Yes, I agree. I think it has to be a solution that checks all boxes, right? Like it reduces cost, improves quality, and makes our patients and doctors happier, right? And I believe we have the solution. We have the distribution patterns. We are the product, right? We as physicians are the product. They can't control us. We have to set our own price. We can't let them set our price.
That's great. I know you're about ready to go beyond a friends and family seed round with this. Maybe you don't want to get into specifics, but you're accepting funding, but you said you want this to be physician owned and physician led. Do you want to speak to that?
Yeah, so the next phase, we want to make certain acquisitions and expand into certain markets. There are a few other DPC physician groups that are similar to us that have started this journey, but they feel stuck because they don't have a complete product that integrates, into a whole insurance plan like we do. They've been selling DPC as a standalone. So excellent people, we want to go acquire them, merge them, and have a large footprint. We are 7,000 members today. We're going to be 15,000 members if we make those couple of strategic acquisitions. We also are looking at a couple of small new tech companies that have entered into this space of kind of the self-funded direct care. And we're looking at acquiring those two also. So we own a lot more of the stack. Our product is more solid. We have a larger footprint. And then we just, again, distribute it through brokers. have a sales team that manages brokers, gets the product out in front of the employers, and then we open clinics in those markets once we get 200-300 employee lives in any market.
And I want to just remind those that are listening to this shorter version of this podcast that they can learn a lot more if they go to the deep dive for this, because this is far more comprehensive than just primary care. This has been a fascinating podcast, and if you'd like to know more, go back to the deep dive. But Geetu, thanks for joining us. If I can summarize, direct primary care model. This is a physician-led, subscription-based direct primary care model, and we're flipping the script. We're really making this about healthcare rather than episodic sick care. But your company reduces costs to employers and patients, increases access to care, all the while increasing personal time and or money in the pocket of the physicians and the nurse practitioners you employ. Is that correct?
That is very correct.
Well, thank you so much. This has been a great podcast. I'm your host, Dr. Jeff Brown, with my co-host, Dr. Jeff Cole. Dr. Geetu, thanks for joining us.
Thank you so much for having me. Much appreciated.
Absolutely.